Good evening, everyone, and welcome. On behalf of the HPV Cancers Alliance, I'm so glad you joined us today for this very important conversation. At HPVCA, our mission is simple yet urgent: to spread knowledge and save lives. We do this by providing clear, evidence-based information about HPV and the latest scientific advancements, advocating for better care standards and supporting patients and families with compassion and guidance, because no one should die of HPV-related cancer. This emerging science webinar series was created to bring together patients, caregivers, providers, and researchers in one shared space to hear directly from experts about cutting-edge immunotherapies, clinical trials, widespread prevention efforts, and innovations shaping the future of HPV-related cancer care. This series reflects our commitment to not only educating, but also empowering our community with hope and actionable insight. I'd like to take a moment to sincerely thank our sponsors, Merck, Insight, BioNTech, Eisai, and St. Jude, whose contributions make these conversations possible, as well as today's esteemed panelists for lending their time and expertise. And of course, thank you to all of you, patients, advocates, professionals, supporters, friends, for being here and being part of this collective effort to drive change. With that, it's my pleasure to introduce our moderator, radiation oncologist, early drug development specialist, my own doctor who saved my life, and my friend, Dr. Paul Romiser. Dr. Romiser is a leader in the treatment of rectal and anal cancers, serving as director of colorectal and anal cancer radiation oncology at MSK. He combines groundbreaking clinical research with compassionate, comprehensive care for his patients and brings deep expertise in clinical trials and emerging therapies. Dr. Romiser will guide us through today's discussion and introduce our panelists. Dr. Romiser, the floor is yours.
Hey. Nice. Can this happen? Okay.
Thank you so much. It's a pleasure to be here today for this exciting webinar series, The Emergent Science, HPV Infection and Early Cancer Detection, that brought to you by the HPV Cancers Alliance. And so with that, I want to start out by thanking all of you for joining us and thanking our esteemed panelists for being here. And we truly have put together an excellent panel for you today. And first, we'll start out by introducing Dr. Stephanie Blank. She's Director of Gynecological Oncology at the Mount Sinai Health System and a professor in the Department of Obstetrics, Gynecology, and Reproductive Science at Icahn School of Medicine at Mount Sinai. She's the Associate Director of the Tisch Cancer Institute and the Director of the Women's Cancer Center at Chelsea Medical Center at Mount Sinai. She's the past president of the Society of Gynecological Oncology and the incoming director of the Gynecological Oncology Division of the American Board of Obstetrics and Gynecology. Dr. Blank is also vice chair of the Energy Oncology Cancer Prevention and Control Committee and a member of the NCI Cancer Prevention Steering Committee. Dr. Blank, thank you so much for joining us today. We're looking forward to your participation.
Thank you.
Next up, we have Dr. Terlizzi, a board-certified general and colorectal surgeon and an assistant clinical professor of surgery at the Icahn School of Medicine at Mount Sinai. Dr. Terlizzi treats disorders of the colon, rectum, and anus, and his clinical and research interests focus on the prevention of anal cancer through the treatment of dysplastic lesions. He's the principal investigator for several HPV-related clinical trials and has given innumerable talks and manuscripts related to anal HPV disease. In addition, he serves on the board of the International Anal Neoplasia Society. Welcome, Dr. Terlizzi. Next up, we have Dr. Brown, a board-certified family medicine physician. Dr. Brown's passion for primary care developed through an interest in the prevention as well as the treatment of disease. While she's a native New Yorker, she's also studied in France and Switzerland, where she worked for the World Health Organization for the Polio Eradication Initiative. Dr. Brown loves teaching and working with both Columbia medical students at the Student-Run Q Center, as well as with Columbia Family Medicine residents at the Allen Hospital. Dr. Brown has a special interest in women's health and providing primary care to LGBTQ plus population. Welcome, Dr. Brown. And last but not least, we have Dr. Jeffrey Young. He's a head and neck surgeon specializing in head and neck cancer and is the chairman of the Department of Surgical Sciences at the Herbert Wytham College of Medicine at Florida International University. He's also the chief of head and neck cancer surgery and physician lead for quality and safety at Miami Cancer Institute. Dr. Young has special expertise and experience in transoral robotic surgery and transoral laser microsurgery. Dr. Young's research interests focus on cancer immunology and molecular disease to further understand disease processes and improve methods for diagnosis, prevention, and treatment of disease. Welcome, Dr. Young. So today in the first section of this emerging webinar series, I want to talk about new aspects in terms of diagnosis of HPV-related cancers. And I'd like to start with you, Dr. Blank. In the setting of gynecological oncology, what are new screening methods and identification methods for evaluating patients with HPV-related diseases?
Thank you. Well, there's a lot to talk about here, so I'll just get started. I think there's a lot. So one thing that's exciting, of course, is self-sampling. So self-sampling, we hope, will allow people that haven't really been screened to screen themselves. Right now, it's FDA approved for people to sort of essentially perform their own pap smear, if you will. It's only approved for people to do it at their doctor's office, and so it basically allows people to avoid a speculum exam, which is something that a lot of people really dislike. It's hoped that this will be able for people to be able to be performed in their own homes, and that would be the goal, for people to be able to do this at home. And so basically it would allow people that really just don't want to go to the gynecologist to be able to do that. So that's one thing. I think a really important thing that should happen in cervical cancer screening would be for it to become just primary HPV screening, and I think that would really also open the doors for more broad screening. In terms of HPV alone, I think also that we are able to use molecular diagnostics to really look at the type of HPV and to triage that way. So when we look at the HPV type, 16 and 18 mean a lot more than the other high-risk types, and we do this already, but that is a big breakthrough. In addition to HPV, we can look at some other things like P16 staining, Ki67 staining, methylation. So there's other things that we can look at in addition to HPV that can be really helpful. I have more things to say. I just got kind of off. But anyway, I'll stop there. But those are some important things. There's a real lot going on. I mean, there's AI that can be used when looking at cytology. I personally think that if we can really move away, this is kind of like heresy to say it, but if we can move away from cytology and look more at HPV, that will really help us in being able to expand screening to underserved areas and all of that. So I will speak a little bit less about AI in that setting. But anyway, that's what I would say for now.
And just a follow-up question for you. There was a recent FDA approval for a home HPV detection kit. What are your thoughts on that? Is that something that people should discuss with their doctors, or?
Yeah, the new one. There is one that you can do at home. So yes, that one I think they can discuss with their doctors. I think that is the way that things will be going potentially. It is worth looking at. These have been proven to be just as sensitive as the regular pap smear, so that's worth looking at if you really don't want to go to your doctor for a pap smear. I mean, a pap smear is not the only thing you do at your doctor's office, so that doesn't mean you don't go to your gynecologist, but sometimes the pap smear is the worst part for people, so this is a good option.
Yeah, that's a great point. That's a great point. Dr. Terlizzi, I want to shift to you for a second. So anal cancer remains underdiagnosed. How can we better integrate anal HPV screening and endoscopy in a routine practice for high-risk populations? And what do you think are barriers in terms of implementing this clinically here in the United States?
I think the number one thing is education, both from a patient side and the provider side. Um, I don't even think realize that anal cancer is a type of cancer because they often associate with rectal cancer. So they think that getting their colonoscopy is good enough for anal cancer screening, but it's not. Um, because colonoscopies are great at looking at the rectum, but really poor at looking at the anal canal. And so I think educating patients to know if I'm a high risk patient, I should be asking for a specific test from my doctor. As far as educating clinicians, um, since anal cancer is still a pretty rare cancer, basically like 2% of all GI cancers are anal cancers. There's just not a lot of discussion, I think, between providers and the patients, but certain groups are at a very high risk of getting anal cancer. For example, HIV positive men who have sex with men, their risk of anal cancer is higher than any other cancer in the general population. So their doctors should be, telling them they should get an HPV test. Also, women who've had a history of cervical dysplasia, they're at a high risk. Men who have sex with men or HIV negative have the same risk of getting anal cancer as women getting cervical cancer before cervical cancer screening became common. So these are all groups that do require screening, and I think just having their primary care doctors realize that these patients need screening would be the first step. Um, I think education is the way to get things moving. Barriers that I see, I just think that primary care physicians have so much to talk about with their patients that are probably much more likely to impact the patient's health than anal cancer, that I could see that getting kind of brushed aside. Um, I think there's still a stigma with the word anus. When I try to use the dictation system to help write notes, anal always gets like starred out, gets censored from my program. So I think people have to be comfortable saying the word anal, saying the word anus. Um, I think HPV is also a stigma that people think it means that they're sexually promiscuous, or it's just one of those things that everyone is exposed to HPV all the time, and it more depends on how their body controls HPV than other factors. So I think getting that out there, that knowledge is important. Also, people think, oh, I never had anal sex in my life. That means I'm not at risk for getting anal HPV, which is also not true. So I think just spreading the word and having people more comfortable with these topics would be super helpful.
It's kind of crazy to hear about those high risk populations. I mean, that seems like they're truly high risk populations that would really benefit from screening and better evaluation. I mean, some of those percentages even surprise me. One thing I want to harp on too, though, is that we see a lot of patients coming in where they just got a colonoscopy and it missed an anal cancer. Can you comment on that again? What's so hard about surveying the anus with a colonoscopy? And just help people understand that, just so that they can remind their doctor to do a digital rectal exam and properly evaluate the anus, or see someone like you who can evaluate it more appropriately.
Yeah, so when a colonoscopy is performed, you insufflate with carbon dioxide or air to kind of distend the colon, to distend the rectum, and that's when the mucosal lesions like polyps can be seen. The anal canal is surrounded by the anal sphincter muscle, so it doesn't get distended with the air. So unless the GI doctor is really focused on the anal canal and look before the things get distended, or something called retroflexion, which you could see part of the anal canal with retroflexion, there are ways that you may pick up an anal cancer. It definitely won't pick up any precancerous spots usually, but a colonoscopy is just not the test to reliably screen the anal canal. Anoscopy is much better. It's very easy to perform because that uses a rigid scope where you could use retraction as you look in the anal canal. That's just not possible to do with the colonoscope.
That's excellent. Thank you so much. Thank you. So, Dr. Young, we're seeing an increase in oral pharyngeal cancers related to HPV. What are the latest innovations in early detection in this space, and what do you see as most promising from your perspective?
So I think your first comment about the increased incidence. So it's been an exponential increase in oropharyngeal cancers over the past several decades. And in fact, we've kind of crossed the line now where the incidence of oropharyngeal cancer in men has actually surpassed the incidence of cervical cancers in women. And in around 2030, but maybe even a little earlier, the overall incidence of of oropharyngeal cancer is actually going to surpass that of cervical cancer. And one of the main reasons is for screening. We have great screening methods for cervical cancer, and that has helped reduce incidence, mortality, morbidity, et cetera. I wish we had those for head and neck cancer. In fact, head and neck cancer related to oropharyngeal cancers related to HPV really don't have any standard screening. So we kind of rely on somebody presenting with the symptom, and believe it or not, the most common symptom is going to be a mass in the neck, because the tumors in the oropharynx are actually very small and they're very well hidden, and they remain relatively asymptomatic until they spread to the lymph nodes in the neck. So most of the patients, at least half, are coming in with neck lesions, and that's how we make the diagnosis. So people have looked at, such a thing as an oral pap smear, et cetera, and there are some clinical trials and things being in development, but nothing's really panned out right now. Liquid biopsies, so blood samples, we can detect circulating tumor markers of HPV-related tumors. There's a good amount of research being done to this to see if this can be used as an early detection or even a screening tool, but that is still being borne out in the scientific community and in the industrial, in the pharma community as well. So we just aren't there yet for oropharyngeal cancers. However, that being said, your dentists are looking in your mouth twice a year. Dentists do pick up tonsil asymmetry. Patients come to me, say, like, my dentist told me my tonsils didn't look right. So kudos to all the dentists who do a good oropharyngeal exam when you're there. You've got a great view. And then primary care as well. Every once a year during the well check, we've all done the open our mouth and say, and I always say, just anything in there doesn't look symmetrical, and there's something that probably should be evaluated. So, we're still relying on, clinical exam a lot for early, for early diagnosis. And I think we could do better.
Yeah, I hope we start to hear some progress in that area. It certainly seems to be ripe opportunity given that rising incidence. Dr. Brown, I'm really honored that you're here today as a primary care physician and as a frontline provider. What strategies do you find most effective for initiating conversations about HPV, especially with patients who might not perceive themselves as being at high risk?
Thank you for having me. And I think what I thought about when I was thinking about this question was, I think it's really important to take with all of your patients a good, thorough sexual history and feel comfortable and make your patients feel comfortable with answering those questions. I think it's important to remove any bias or preconceived notions that we might have as physicians. We come from all different walks of life as to what kind of sexual practices our patients may engage in. No sexual practices are bad, except obviously for trauma. But it's very important to make your patients feel comfortable and to build that rapport with them. And sometimes just asking it of everybody in the same way can be helpful. So, always saying, do you want to have any STD screening on their annual physical? I let people make the decision for themselves. And then if they say yes, I always follow it up with, do you perform oral sex? And I will get a lot of varied reactions to that. But I say it's just important. I just need to know where I swab. And then that makes people tend to feel at ease. And then I ask the same question, do you have any, anal sex? Do you receive any anal sex? And I ask it of all patients, all ages, all races, all identities and sexual orientations. And a lot of times I'll get patients who are diagnosed, maybe not with an HPV related problem, but with an STD that had gone undiagnosed for a very long time. And I think it's important to make sure that our patients feel comfortable talking to us about these things, because I agree certain words and terminology are considered shameful or embarrassing and we don't address them. But there shouldn't be anything shameful about our sexual preferences. And then I think also I talk with people about the fact that HPV is spread through sexual contact, not only penetration. And one thing that I feel hopeful about is that I actually have a lot of young patients who come in having heard things from other providers about sort of like, oh, you don't need to worry about this. You've never had sex, or you never will have penetrative sex because you're a woman who has sex with women, which we know that is not the case. Everybody should get screened for cervical cancer in that situation. And then we have these higher risk groups in other situations. And so I feel hopeful that patients are coming in a little bit more informed, especially younger people, and sort of saying that felt weird to me, that felt off. And so, we talk through what their risks are as well, in a way that hopefully is comfortable and they can feel open to share. Um, and then also not pushing people when they don't feel comfortable. So I will have people come sometimes 3 times to be able to get their first pap smear because it's painful, they're scared, they had a bad experience, and I want them to feel comfortable coming back to me. So whatever we need to do to make it happen, we will. And then I think it's also important to mention to people in the primary care setting that HPV causes not only cervical cancer, but cancers of other parts of the body as well. And that will lead to a discussion where people say, oh, well, actually, like my, a family member had that, or, oh, actually, I feel something here, and we'll have a conversation about it. So I think it all starts with that open and honest communication with your.
No, thank you so much. I think that's so important to have that open communication and trust with your primary care physician who's really kind of leading these interventions and guiding patients on the front line. So I just want to reiterate those points that you made. So I want to shift a little bit to some of the advancements that have been made recently and kind of highlight how they've been applied in clinical care. So Dr. Terlizzi, I want to start off with you. You've been involved in the ANCHOR study and have led other HPV-related trials and education on high-risk endoscopy. Can you share some of the promising insights, tools, and what's come out of that work, and how you think this might shift how we're thinking about diagnosing disease, especially with earlier detection?
Sure, yep. So I think it was really hard to get people on board to do anal cancer screening before the results of Anchor came out because there were no real guidelines. There were a lot of small trials that showed that it seemed like treating these precancerous lesions reduced the risk of anal cancer, but there was never a randomized controlled trial to show it. So since Anchor came out, I've noticed many more physicians are actually interested in screening their patients, which is a positive thing. The funny thing is there's never a randomized controlled trial that showed that cervical cancer screening was effective, but it's been standard of care for decades now. So I think since the results of Anchor have been out, there's a lot more interest. We kind of steal how we do anal cancer screening from the gynecologists, which is, an anal pap test or cytology, high-risk HPV testing as kind of our first line test to see who moves on to high-resolution anoscopy, which is basically colposcopy of the anal canal. We're also trying to move more toward primary HPV testing as opposed to cytology, but that's still very variable depending on which healthcare system you're in. It's one thing that's going to be great coming up with all the Anchor data, because we have so many biopsies from patients that hopefully now maybe we could innovate the field from the gynecologist to say, okay, not all HSIL will turn to cancer, which HSIL needs treatment. So we're doing a lot of molecular studies on the biopsy specimens, like methylation patterns and other types of molecular studies to see, do we really have to treat every HSIL spot, or there's some that may regress, some that may stay HSIL, and which ones would progress to cancer. So hopefully, in the years to come, we'll have, more tailored treatment for each patient.
No, that's great. Thank you so much. And thanks for highlighting those findings from Anchor and how it changed. And yes, we're all following in the paths of the gynecological oncologists who have really led the way here. I'll definitely back that up. So shifting now to you, Dr. Blank. So you've been involved deeply in fertility preservation and survivorship, which are critically important for many different cancer patients. How do your conversations on HPV or early diagnosis shift when the patient is of reproductive age or has concerns about fertility, both for gynecological cancers or other cancers of the pelvis?
Yeah, so cervical cancer has a bimodal distribution. So there's a young, peak of incidence and then older. So we do see a lot of young people with cervical cancer where fertility still is a concern. And there has been, since we're talking about sort of new things, there's been some recent research that has shown that you can perform some fertility sparing treatment that can be safe. So we can't, situations where in the past we would have performed what's called a radical hysterectomy. Now we find that we can actually perform a cone biopsy, which is basically like removing something that looks like a dunce hat, if you will, and lymph node and that can be safe in certain, very well selected patients. So we are really moving, towards, less invasive care. And of course, all of our treatment for high grade dysplasia, sort of the pre-cancer, if you will, what you were just talking about, does involve doing, procedures that have the potential to not necessarily negatively impact getting pregnant, but the ability to carry a pregnancy. So that's a discussion we have every single time we're treating this. So it's always a discussion, and the treatment always is, it's a different treatment depending on whether fertility is an issue or not. I think that, there was a time when that was never even considered. It's like, you have this, you have to have this treatment, forget it. But now I think it's really recognized, and our large organizations such as ASCO and, everybody has done a much better job in considering fertility as a big survivorship issue, and we've done the same.
Great to hear how that's being taken on a patient by patient basis. So I think that's super exciting to hear about. Dr. Young, there's tools like transoral robotic surgery are changing outcomes for HPV positive patients. So when do you decide to intervene surgically, and how do you weigh treatment with other modalities, particularly chemoradiation or things that are non-surgical based?
So, I think oropharyngeal cancer is one of the classic cancers where a multidisciplinary evaluation is very important for the reasons that you just said. The one thing of note is that the HPV-driven cancers of the oropharynx actually do well treatment-wise, regardless of what we do. It's trying to save the patient from all three modalities. Like, we don't want to do surgery, radiation, chemotherapy. So we pick surgical patients who we feel that if we do the surgery, we're likely going to either take away chemotherapy or take away radiation or both. Sometimes it's done for staging purposes. Sometimes the patient will have, bulky disease or advanced disease or disease that we just can't handle surgically, and then they go the chemoradiation route. The interesting thing about the robot is it's a good line of vision. And everything here in the back of your throat, your tonsils, your base of tongue, it's around a corner, right? So you can't see straight in. So this robot gets you around the corner, and it brings in little instruments that you can use to just do a very nice oncologic surgery without having to do something radical to access that area. In the past, there were, things splitting the jaw. Your patient would have to have a trach, be in the hospital for 2 months. My patients go home the next day from transoral robotic surgery. But you also have to address the neck as well, because there are a lot of disease, like I said before, patients that come in with metastatic disease in the neck. But I think what it has done is it has allowed us to kind of customize treatment based on patient preference, disease severity. And I can tell you, very rarely, we see patients, myself, the medical oncologist and the radiation oncologist, we see almost 95% of these patients together. And I would say that very rarely do we ever disagree on the treatment. It's usually kind of a thing that's very, it just gels with the patient's wishes, with whether surgical candidate or not, et cetera. And almost always the entire team is in agreement. So, but I think you have to have that conversation. That multidisciplinary conversation is very important.
Which got to highlight, that's what makes a good cancer center great, is multidisciplinary collaboration, knowing that your surgeon, medical oncologist, radiation oncologist are talking, and that they're deciding that together. That's what you want to hear from your team when you're meeting them, if unfortunately you have cancer. And I think that highlights it. I'll say that the robotic advances in the last 10, 15 years, phenomenal. I mean, every time I walk in the OR and see a robot, I get more and more amazed by what you guys can all do with them, because it's really, as you just mentioned, transformed cancer care. I mean, the fact that they go home the next day is wild. So thanks for sharing that. Dr. Brown, what tools or workflows in the primary care setting do you feel are really underutilized or could help improve HPV-related early detection and conversation with our patients?
I think it's challenging in the U.S. because we all work in different electronic medical records. We all we can be siloed. We aren't always siloed, and I would echo what you said about a multidisciplinary team for any kind of cancer management. I like to insert myself in that team as a primary care doctor. So I like to message all the specialists and, make sure that I am understanding why sometimes patients are scared to ask why. And I feel fortunate to be in the position of as a primary care doctor where patients will say, I was too scared to ask the surgeon this. What's the answer? And I mean, I'm sorry that that happens sometimes, but and also I don't know the answer most of the time because I'm not the surgeon. But I really appreciate working in an environment where specialists, you know, talk with us. You know, everyone is part of a team. Everybody's doing the best thing for the patient. That's really the key. So I definitely think that that's a big part, and it's not a workflow for prevention, but it is a workflow that proceeds once the diagnosis is made. And that's really important too. And I appreciate I'm very grateful that these people are here with me today, to include this conversation, because I was even saying in sort of thinking about this and preparing for this, I learned a huge amount. I know I got myself caught up with some new changes that have been made, read some new studies. And I think that's actually something that's really important when we're talking about moving this forward for our patients is academic excellence and making sure that you're staying up to date with things, being able to communicate with the people who are performing the treatments, and then you are following up with the patients afterwards. That's really important. Sort of on like a nitty gritty workflow level, I actually think that one of the biggest changes can be we all work in EMRs. We all probably work in the same EMR at this point, but is we have these different parts of the electronic medical record that keep track of healthcare maintenance. It's the thing I use the most. Not everybody uses it, but I think advocating with electronic medical records in our different organizations and working with our informatics groups and things like that to say we want to make sure that these are screenings that get put up there with cervical cancer screening, breast cancer screening, like that we can put into the chart for the patient, this patient is at risk for these things, and it'll remind us, because we do as primary care doctors, as you said, have a lot that we have to think about in an annual. And having those sort of care gaps that are not noted is really, really helpful. So I think sometimes harnessing the technology we have is the best way forward in a lot of ways.
Yeah, I just want to highlight on that end, what makes a primary care doctor not good but excellent are the ones that will call your oncological team, that will integrate with your oncological team, they'll be open to talking with your oncological team and managing the complexity of the cancer treatment. And I just want to highlight that because those are few and far between. But personally, I love that. I love getting a call from the primary care doctors, because after we cure the patient, which is oftentimes our goal, we want them to be not just survivors, but thrivers. And we do that by working with the primary care team and all sorts of other ones. So thank you for that. And just, again, point that out. So I want to kind of shift to try to open this up a little bit more to a conversation really about different specialties and exploring system level improvements. So I want to start by asking a question for all of you to answer. We'll see how it goes. Let's try to make this a little bit more like a dialogue for our audience. So screening guidelines for HPV-related cancers differ by anatomical site and population. How can we better standardize or streamline early detection efforts across specialties? Should we? And if so, what are the technologies or ways we can start thinking about it? So more or less, where do you think we're going to be in 5 or 10 years, and how can we bring that across all different specialties? Does anyone want to volunteer to go first?
Well, if there was something that was serum, it would work for all of us. Serum based, sorry. Yeah, work for all of us.
So I leading back on what I said, so coming from we don't have a great screening system yet, but I think what we've hit on in a couple of points. So first of all, the pandemic taught us a little bit about cancer, and we know that there were a lot of opportunities for delayed screenings where cancers presented a little bit later stage because we had that year where there was limited access to care, so we had some disease progression and missed screenings during that time. We all don't ever want another global pandemic, but there are going to be places and times in our lives where there is limited access or restricted access to care. And so having things like evaluations, liquid biopsy, things that you can get a kit in your home, do the test, and send it out. That's going to be not just for all types of cancer screening. So I think in the HPV related world, we do have things, circulating tumor markers, et cetera. We have the ability to, self-test some of these, regions and areas, and it might be more comfortable for people to do that in their home than seeking care, and then they might not be able to seek care. So I think these kinds of lessons have taught us that this is probably where we should head in the future, with screening.
Yeah, I think that's a great point. I take it back about the serum because that's going to just make you say, where is it? So I think the specific self-testing is a great idea.
The serum's not, it could be a starting point, right? It could be like level 1, we see Dr. Brown, let's do a serum test, get a serum test. Okay, well, maybe then we need to do site specific.
I think it's, I think it also comes down to, a lot of screening is how do you define the population? I think that was part of the question. I don't think HPV screening, unfortunately, is going to be ready for global screening anytime soon. So we're going to have to look at high risk. We have a lot of people bickering about who's high risk for oropharyngeal cancer. It goes back and forth all over the place. And we basically loosely know that maybe there's some loose association with the number of sexual partners in your life, but it's very loose. And so, but there are some other, disease sites where there are high risk criteria that can be identified. And I think, you always start there. And if we can start there and then start to globalize it as these tests become more utilized, more validated, et cetera, then hopefully we can get it out to the masses. That would be the ideal.
Dr. Terlizzi, so I view, again, I don't want to harp again on the anger study, but that was a critical aspect, showing high resolution endoscopy and intervention with doctors like yourself could actually prevent cancer from forming. Is that something that is widely rolled out now in the United States for high risk populations, or how's that evolving? It's just one case in point for our audience.
Yeah, the problem with anal cancer screening is that there aren't great guidelines. So the big organizations like USPTF, who makes these guidelines that primary care physicians follow and different doctors follow, there are no guidelines for anal cancer screening among any population. The American Society of Colorectal Surgeons has weak recommendations for screening patients, but that's the problem with anal cancer screening. I think once these organizations really put out detailed guidelines of who should be screened, how they should be screened, then we could make some progress. Even NCCN guidelines for surveillance of anal cancer does not include cytology, HPV testing, high resolution endoscopy. I believe that USPTF was we brought getting guidelines from them, and they said that there's not a huge need for anal cancer because it's not something that's on their radars. It's such a small group of people are at risk for it. So I think we just have to get these organizations to understand the importance of having guidelines to start screening.
Dr. Brown, how do you feel about the guidelines? Do you always stick to them? Do you ever expand beyond them? I don't know. What do you think?
I don't do as much anal PAPs as I want to or should. It's something that I also need to talk to colleagues and make sure this goes for myself, goes for any primary care doctor. It sort of gets to concepts of teaching and in residency med students, things like that, which is really important as well, is making sure that we're teaching it in a broad way that's easy to follow, that we have the right tools, and that we're doing the procedure in the correct way, because you also want to make sure that you're not getting an inadequate sample and that you're not making errors and things like that in that way, so that you give someone a false negative, right? Of course, these things will always happen, false negatives, false positives, but we want to make sure that when we implement it, we do it the right way. I think one thing that is very interesting, and I think is hopefully the future, is the self swabs for cervical cancer screening, and it's been implemented in other countries very successfully. I having worked at the WHO, and although that was in polio and not in any of these areas, but I have been in communication with people who live in some of the countries where where it's been implemented, Denmark, Australia, the Netherlands, and I think the data has demonstrated that it increased screening by about 17% of people who hadn't been previously screened because they were able to get the testing kits to their home and do it on their own. And I think the other large portion that's very important for are people who have experienced trauma, and a speculum exam is really not possible for them. But offering them the opportunity to do it for themselves is really important, and you're going to get a whole lot of people screened that way who wouldn't otherwise be screened, and they'll be able to do it in the comfort of their home. Possibly they'll come to the doctor's office. It'll create a bond between you and your patient, and they'll feel like you've offered them a option that makes them feel like psychologically safe, and they're more likely to get screened that way. So I tend to stick to the guidelines most of the time, but I do always use shared decision making, which is very important in primary care. And I try to meet patients where they are, which is what I teach the residents that I work with and the medical students, because I think it's really important. Everyone has different histories, different risks, and you have to think about those things as well. And I think that for the people who develop anal cancers, although it's a small proportion of the population, it's very devastating. And so always thinking about that this is an individual that you're working with and not just a number.
Absolutely, patient first. I mean, I've heard from some providers that they have a high-risk patient, they want to do an anal pap, and then they don't even know how to send it, right? I mean, there's barriers even in 2025 if you want to do one of these things and step outside the box a little bit.
I'm going to just make a comment about guidelines, because everybody's used guidelines. Guidelines are wonderful things. But having been on numerous committees in numerous societies, when you say the word guideline, people look at you like suggesting you're robbing a bank. Everybody hates to hear that word because it is a tremendous amount of work to change a guideline, propose a new guideline, et cetera. But it's important. And the societies really need to start thinking about that, because guidelines make it into the EMR. Guidelines do trigger pop-ups, so forth and so on. So it's time to do some of the work, and I think there are opportunities for guidelines and screening. And I know it's difficult, but I do urge the societies to to think about taking some of this on, because it does make a difference in recommendations. And again, with this interdigital connected world and EMRs, et cetera, the guidelines make it in there.
Absolutely. Couldn't agree more. Dr. Blank, I want to ask you a question. So you're the vice chair of the Energy Cancer Prevention and Control Committee. Can you comment about what that committee does in terms of cancer prevention and guidelines? And
It's really more about trials, I would say. I mean, in terms of the things that we're talking about, there was a trial looking at P16 staining for PAPs and things like that, but it's not a guideline creating body.
But is the trial result, is the goal to change or update guidelines or modernize them?
I think if the results can be practice changing and can result in going into the guidelines or the NCCN guidelines or things like that, yes.
Yeah, and I think, a lot of everyone strives for a trial to be practice changing, but sometimes it does take a while, maybe what some of us feel like too long to get into the guidelines.
Right, especially prevention trials.
Historically, the U.S. doesn't do great prevention trials, unfortunately. So next question, artificial intelligence, self-sampling, molecular diagnostics. We've heard about all this today. They're gaining traction. Everyone's interested in them. They're the next big things, but these are really emerging tools. What do you see as the most potential, again, to transform HPV-related care in the next 10 years?
There are, I think, two companies I know of that are looking at using AI to determine which lesions we find on high-resolution endoscopy would require a biopsy, or maybe not even biopsy, but just treat. Because right now, like with the gynecologists use acetic acid and Lugol staining, anything that looks abnormal to us in any form with those stains, we do a biopsy. If it comes back as a precancerous spot, then we'll bring the patient back to the office and treat them. With AI, the hope is we could just use AI to look at the image in real time and say HSIL, no HSIL, so the patient doesn't have to get unnecessary biopsies or come back for treatment later. Also looking at new molecular markers to determine which HL will progress to cancer, so we're not over-treating our patients.
Yeah, I think that's interesting. I mean, a big part of all of this is the implementation science. I mean, I think that's really, really hard. The number of visits people have to do and the follow-up is really, and I don't, is really a lot. And I think there's not a lot of investment in implementation science research. So I think that's a big deal. I really think this self-sampling is really, really important. I think on a worldwide level, I think that is the most important of these things, honestly.
And I think, AI, and it's been mentioned, this is a good tool to, help define, like as a second look for something for the pathologist, as a, we can use them to screen, et cetera. Maybe we do the same thing with oral premalignant lesions. People are looking at AI to determine what needs to be biopsied, what doesn't. It's very painful to biopsy something in the tongue, obviously, and you don't want to put people through unnecessary biopsies. So I think AI can help us refine what we're doing, refine criteria, et cetera. It's still going to be, I think, getting it into the hands of the public, the self-sampling, and is going to be one of the more important ways to bring things forward.
I would just say I agree with self-sampling, and I think it also is important for those patients that we have. New York City is not in this category, but we're talking about the entire country, and it's very difficult for some people to get to a doctor's office. And so if it's something where it gets mailed to people and they're able to do it and mail it back, like a Cologuard does, like a FitKit does, that has a lot of potential for our rural patients and people who don't have access to close medical care, especially for things like the follow-ups. If we want them to be taking the time out of their lives, we want it to be for treatment if they need it rather than for prevention. And I agree. I obviously want people to come annually to their annual physicals. But I think it would be great if when they come for their annual physical, I'm talking to them about their resulted pap smear that they did at home. And instead of being, okay, now we can't continue to talk about this thing that you have a concern about because I need to get to your pap smear. So it has a lot of potential there too.
Yeah, and add on worldwide too, because I mean, while in the U.S. cervical cancer deaths are low or lowish, worldwide they remain incredibly high, largely due to lack of screening in rural communities and poor communities. And it would be wonderful to see this make a dent in that worldwide. I think that would be really a big game changer. So you guys are all leaders and educators, and tell us a little bit about how you're training the next generation of providers to better recognize and act early for HPV-related diseases.
So I'll take this by starting. First of all, I think I go to the very basics with them because any medical student, resident, trainee, et cetera, needs to be reminded that every single disease we're talking about today is preventable potentially with a vaccination. So first thing is to remember to have them educate their patients about HPV vaccination, which is now up to 45 years old and beyond, depending on the circumstances, but up to 45-year-old for most men and women in most cases. So I think reiterating the importance of vaccination for these cancers is high. And then I think educating people how to have conversations with their patients and building that trust needed to get them through screenings, to get them through their healthcare limitations, to get them through their cancer treatment if they're already diagnosed. We talked about the importance of a multidisciplinary team. I think that physicians, when they see that and they see that in action, understand the importance of it. No matter what specialty they go into and no matter what level of training they're in, I think it's very important to expose them of all aspects of patient care. And so they're not just laser focused on that one thing and they kind of keep the whole perspective in mind. And I think that's how we keep advancing things forward, by bringing it all back to the patient's story and journey.
Okay, we can go down the line. I agree 100%. I think vaccination is key. We've seen tremendous effects already of the vaccinations and decreasing cancer rates and positive pap smears, etc. I also make sure to talk to trainees about to keep a broad differential in general when you're thinking, especially from a primary care standpoint. But things like, somebody who's come in and they, historically we have, this may be a very old way of thinking, but sometimes I think those things get perpetuated is, like, somebody who's a heavy drinker or smoker, that those are the people who are at risk for oropharyngeal cancers, when we have to remember HPV is part of that as well. And so, somebody who's had a persistent sore throat or sort of, asymmetric tonsils or things like that, to have this and ask like, oh, have you gotten your HPV vaccine in the past? We are in an interesting time where a lot of people have. Some people's parents were hesitant, so they didn't, and they don't really know if they've been vaccinated. Other people were, the vaccine did not exist, so they haven't been vaccinated. And so always keeping these things on their differential in order to not forget about things or attribute, not have tunnel vision and attribute things to what we have historically thought they could be. And then the other thing that I work with my trainees is, if it isn't already built into the medical record, the electronic medical record, is to have your own either dot phrase or smart phrase or whatever terminology you use in your medical record of healthcare maintenance, so that you are always making sure that you have your list and you have it for different people and different risk groups and things like that, to make sure that you're remembering to ask them about all the screenings that are relevant for them, including other things that we aren't talking about here, but CT lung screenings for smokers, and going through the risk calculator for people who are at higher risk for breast cancer, asking about family histories of ovarian cancer for BRCA testing and things like that. So making your own, as a trainee, list that you'll continue to use and update as more and more data comes in is really helpful to have as a reminder when you're seeing new patients.
It's amazing how you keep track of it all, because it is complicated, and that's why it's good to have an open relationship. Yeah, it's key. It's absolutely key.
So for anal cancer screening, there are just not enough providers who do high resolution anoscopy. So I try to train anyone who's interested. So I have people come to my office, colorectal surgeons, general surgeons, nurse practitioners in primary care, infectious disease specialists. This is like a skill that could be done by pretty much any healthcare professional. So anyone watching who's interested in anal cancer screening, I really encourage you to find either me or someone like me who you could shadow in the office, or join IANS, which is International Anal Neoplasia Society. I have lectures to contribute to the education process, both on the theoretical lectures about what is HPV, what is anal dysplasia, how to recognize the spots, as well as like hands-on courses. So at all the IANS meetings, there's always an HRA course. Sometimes they precede like the colorectal meeting or the international papillomavirus meetings. So if you could join IANS if you have any interest in learning to do HPV care, which is a little plug for that organization, because it's super important to get more clinicians trained in HRA, so that when primary care is doing their PAP tests, they have providers to send these patients to.
And that's an open invitation if you missed it, to come and learn from one of the best. So open invitation. You don't get that very often on a webinar series, all right?
Yeah, I'm OBGYN residents are usually pretty familiar with HPV and such. I think one thing I like to make them aware of is the importance of the other HPV related cancers and thinking about them. I like to remind them about catch-up vaccines. I mean, so for people older on the spectrum, they're not old, but older in the spectrum of the indications for HPV vaccines, and also thinking about vaccines, after you do, say, a cone or a leap for HPV, that it's been shown if you do a vaccine, then it's less likely to come back. So that's another thing that I really feel strongly about. And then the last thing is specific to GYN, or maybe not, but like when you're not just screening, when you need to make a diagnosis, like don't do a PAP when you see a gross lesion. So screening, diagnosis versus screening. Big deal.
Well, certainly teaching the next generation is important, and this is a webinar series, but I'll just point out for you at home, we're joined by some residents in the room, so we want to thank them for coming today and learning with us. I think it's really highlights a proactiveness and a care, a patient-centered care, so thank you so much. And just one more thing, because we heard about the HPV vaccine. I'm a vaccine believer. I believe the HPV vaccine is safe. I encourage you all at home to please speak with your doctors, speak to your primary care providers about the benefits and potential risks of the HPV vaccine for yourself. My favorite statistic on it, if it was implemented worldwide and was efficacious in all patients who received it, it would eliminate 5% of cancers worldwide. There's very few interventions, single interventions that you can do that will eliminate 5% of cancers off the face of this earth. So please speak with your primary care doctors and everyone you can about the pros and cons of vaccination. It's up for you to decide. In the closing remarks, I just want to ask you all, can you share one message with the other professionals in your field about their role in addressing HPV infection, prevention, and detecting HPV-related cancers? What would it be?
Promote the HPV vaccine. I mean, it's the vaccine. That's my number one message, honestly. Any forum about HPV.
That was my message also.
Yeah, that is the number one thing, I think, vaccination. And to the colorectal surgeons out there, if you're treating anal condyloma, make sure that you don't just say goodbye to your patient once they heal, because this is something that's going to keep coming back, and make sure you screen them for high-grade dysplasia in addition to the condyloma.
Education and destigmatizing HPV and promoting the vaccine. I think the top three. We have great evidence. There was some data presented from Australia in the most recent papillomavirus meeting where they have a 95% vaccination rate, so they're almost there to that full uptake, and they have significant decreases in HPV-related cancers that they're starting to see, as well as rare diseases that are caused by HPV that they haven't seen cases of in years, where we're still seeing cases in this country of some of these diseases. So it works, and it's preventative and potentially therapeutic, and when done with procedures. So all kinds of reasons to talk to your doctor about it.
Well, with that, I want to thank all of you at home. I want to thank the HPV Cancers Alliance for this amazing emerging webinar series. And most importantly, I want to thank Dr. Blank, Dr. Terlizzi, Dr. Brown, and Dr. Young for joining us today and volunteering their time. So thank you for joining us. You heard all about what our biggest message is. It's about prevention. It's about vaccination. Please talk to your providers. Thank you so much for joining us.
Thank you for moderating. Great job.
Thank you.